Community Health. I'm Dr. Anthony Gonzalez with another important health topic for you. We're in the month of April, and April is Head and Neck Cancer Awareness Month. The head and the neck, obviously a very important part of our body. I learned very early on there's a lot of anatomy going on here in the head and the neck, and cancers can occur. Cancers can occur in the mouth, in the throat, in the nose, in the salivary glands. And so cancers in that area are very important, and they're very difficult to treat. And so because of that, we brought a head and neck cancer specialist from Baptist Health, Miami Cancer Institute, to talk to us about head and neck cancers. We want to bring awareness to this and learn about this topic. So I brought Dr. Megan Crawley. Welcome.
Hi.
All righty. So tell us a little bit about what a head and neck surgeon does. What is it that you guys do, head and neck cancer surgeon?
So head and neck cancer, we remove tumors from the head and neck. So above the clavicle, not the brain, not the eyeballs, but everything else is fair game. So we remove tumors that are in the salivary glands, as you mentioned, thyroid, parathyroid. We'll do neck dissections, sinus surgery if you have a tumor in the sinus. So we'll cover that whole range.
And is it true that I think in anatomy, a few years ago in medical school, just a few years ago, there's the same amount of anatomy from the clavicles up as there from the clavicles down. Is like so much anatomy up there. There's a lot of condensed anatomy.
Yeah, the anatomy's extremely dense. So I do notice when the med students come through, they kind of struggle with it and they don't know where they are at. But yeah, it's a very complex place, which is why I love it.
All right. And that makes surgery and treatment more difficult, doesn't it?
Yes, because there's certain structures that you absolutely cannot sacrifice. There are structures that we have to really consider the quality of life of the patient if we do sacrifice those structures. So it does make it complex.
All right. So we're going to talk about head and neck cancers, and we're trying to bring awareness to our community about head and neck cancers. So what is head and neck cancer in simple terms?
So as you mentioned earlier, so it can be any kind of cancer that can happen above your clavicles, and so that falls in our category. So that can range from skin cancer. So if skin cancer gets extremely deep or invasive, or it gets very large, typically dermatologists will refer patients to us to resect it. If they have metastasis to the lymph nodes in the neck, that's something that we cover. Also, the salivary glands are a common place to have a cancer, the oral cavity, the back of the throat, the larynx, the voice box, the thyroid. So
the tongue
too, yes. So the oral
tongue,
cavity, so
yeah,
the
tongue.
Along the teeth, everything. So
wow. Okay, and so what are the most common types of head and neck cancers that you guys see that you deal with?
What I see most often of malignancy is I see a lot of oral cavity, and I see a lot of laryngeal cancer.
And so oral cavity is anything in the mouth?
Yes. So that would
be... And laryngeal cancer is the voice box? All right.
So the oral cavity would be the tongue, the gums around the teeth, the cheek, the palate, all of that area. Now,
for our public and for our audience, obviously not everything you see or you have in your mouth is going to be cancer. Right. Explain to us, what are people, God forbid somebody feels something on their tongue or their cheek or their gums, what are the things that they should be looking for to be concerned or not to be concerned?
So if you have a lesion that's like something in your mouth, a sore or something like that doesn't heal after 2 weeks, or if it's getting progressively worse, then I would see a medical professional about it to take a look at it and see what they think. Typically, head and neck cancers will be in the mouth, will be painful. They won't be getting better with time. They'll look like they're getting bigger. So those are the things that we kind of look for, that we'd be suspicious that something else is going on.
And what about lumps, if they feel any lumps in their neck? How about that?
So palpating the neck is helpful to help find it. That's actually a very common way that we find cancers that happen in the back of the throat. So in your tonsils, most people won't notice a mass in the tonsils, and even medical professionals won't catch it. So you'll actually feel or have a mass in the neck, and that's how we find it.
Okay. So what causes these head and neck cancers? I could imagine already probably, things like smoking probably, right?
Absolutely.
But what are the common causes of head and neck cancer?
So smoking obviously is a very high risk factor. So that can cause oral cavity cancer, the voice box cancer. And it also just makes it, even if you have an unrelated cancer to smoking, it makes that more likely to come back. So it will affect your prognosis even if it's not directly formed
Related
from
from smoking,
right.
okay.
Smoking and drinking together makes it exponentially more carcinogenic. So by smoking and drinking, so let's say smoking increases your risk by 2 times, drinking alone increases by 1.5 times. You put it together and it's 5 times increased
More,
risk.
right.
So those are the things that commonly cause it. The other thing that can cause head and neck cancer is the HPV virus. So that's human papillomavirus. Most people associate that with women's cervical cancer. So that can actually cause tonsil cancer and the back of the tongue or the base of the tongue cancer. So that's something that we've been seeing more commonly. It's a newly identified type of cancer. So the way that we find that is, again, usually with a mass in the neck. But the good news about that kind of cancer is that it's very treatable. It's very responsive to treatment. People typically do very well.
Now, the HPV, isn't there a vaccination protocol or there's a move to vaccinate people for HPV?
Yes, absolutely. So the vaccine came out to the general public probably around 2007. So the recommendation is for kids, I believe, at around age 9 to 11 to get the vaccine before they have any exposure to close contact with the opposite, like with their romantic partners, because HPV is transmitted by close contact, so not necessarily by sexual activity per se, but by close contact. So, and majority of adults are exposed to HPV at one time in their lives, and then majority of the people will clear the virus, but a small subset of people, the virus will incorporate into their DNA, and it can turn on some genes that unfortunately form cancer.
Okay. So we learned about smoking, drinking, and the cumulative effect of both of them together. What about chewing tobacco? And what about all this vaping? How does that play into the risk?
Chewing tobacco, 100%. That is we see a lot of cancers that'll happen along the gum line or in the right behind your lips where you tuck the tobacco. We'll also see a lot of tongue cancers that can happen from chewing tobacco.
Okay, so chewing tobacco, yes.
What was the other?
The vaping.
The vaping, yes. So vaping, I don't know yet. We don't have that. We don't have any data on it yet, honestly. It's a little bit hard to tease out. I mean, we'll have to see. It's going to be interesting to see that kind of data come out. I typically counsel my patients, maybe consider it, but they may be doing more damage to the lungs. Again, there's been some data that shows that it's pretty horrible for your lungs. So, I try to tell people not to do it.
Okay. All right. So we learned a little bit about the risk factors for head and neck cancer. We understand what it is. Who does it affect? Men, women, young, old?
So we see it in all ages, all walks of life. Most commonly, I see it more in males. And for age, it depends on which kind of cancer you're talking about. So for HPV-related cancer, it's most commonly in men, and it's most commonly in younger men than when we consider cancer creeping up. So typically it's in males, typically in their 50s, 60s that we'll see it, but we have been seeing patients that are younger. I've seen people as early as 40 years old get it. And other types, the other subsites, they're typically in older patients, And
again, mostly men as well?
Yeah, I would say there's a male predilection.
All righty. And in regard to the prevention, how do we prevent these? Besides eliminating the risk factors, obviously, if you don't smoke and you don't drink or you don't do those things, is there any other way to prevent head and neck cancers?
We don't have the data yet because it takes there's a long lag time from getting the vaccine, the HPV vaccine, to when people are getting head and neck cancer. But we suspect, based on the cervical cancer data, that the HPV vaccine will be really integral in preventing base of tongue and tonsil cancer. The other things that you can do is if you're a woodworker or you're working around chemicals, that can increase your risk of certain cancers in the head and neck. So you want to make sure that you're protecting yourself and using the precautions when you're working around those materials. People at higher risk are also people that have had radiation treatment. So if you had a childhood cancer and you had external beam radiation, you're at higher risk for having a secondary head and neck cancer. So those people should be watched closely. There has been some data that shows that poor oral hygiene may contribute to the formation of head and neck cancer. So, we recommend that people maintain good oral hygiene, see their dentist regularly, those kinds of things.
And the radiation has to be in this area, right?
Yes,
not
correct.
radiation for cervical cancer, prostate, or whatever.
Correct. So if it's if this area is exposed
with radiation. Okay, so let's go through the steps of what happens with a patient. You have somebody who's listening to our show. They have a lesion in their mouth. They go to their doctor, and the doctor is concerned about the lesion. What happens when somebody ends up in your office? Are they already had the diagnosis? Are you trying to make the diagnosis? What are the steps and the kind of tests and that people are going to get to try to find out what they have?
So most commonly, patients will see either their primary care doctor or they'll see a general otolaryngologist first, or an ENT. Sometimes they'll have a biopsy done by an ENT before they come to me and they already have the diagnosis, but sometimes people come to me before they have a biopsy. So they can kind of come to me in any stage. So one of the things that we'll do is obtain a biopsy. The next thing to do would be to get imaging. So to further characterize the disease, make sure, see how deep it's going, what's involved, what structures are involved. So we get the biopsy, we get scans, and then from there we come up with a plan.
All right. And so the treatment plan, is the treatment plan chemotherapy, radiation, surgery, all of it? You know, I'll give you an example. A lot of times, like in breast cancer, it's a lot of chemotherapy before even surgery, and so forth. In rectal cancer, radiation even before surgery. So everybody wants to have surgery right away because patients believe that surgery is the only way to cure cancer. And we've learned that there's other ways to do it even before surgery. So what is kind of the treatment algorithm for these patients?
So we found that if surgery is in the plan for head and neck cancer, that needs to happen first. Rarely do we see that it's rare that we give chemo before surgery. There are some instances that is recommended, and there have been some studies. It's still early to see if immunotherapy can be used before surgery. But at this point, the standard is pretty much to do surgery first. If it is able to be resected, surgery is the preference. Depending on the site of the cancer and what kind of cancer, they're all very different. Based on what kind they are and where they are, what kind of treatment we recommend. But majority are surgical. If they're not able to be resected, then we'll consider doing chemotherapy and radiation, or radiation alone. So the big mainstay for us is surgery is probably number one, then radiation is number two or equal as surgery. And then chemotherapy is mainly just a helper. It's not one of the primary ways that we treat it. It's used to help boost the radiation and make it a little bit stronger.
So let's talk a little bit about the surgery. And so the surgery, as I know, because we kind of work with some of the same instrumentation surgery, some of the surgery is quite minimally invasive where you're doing surgeries through people's mouth and resecting tumor. But some of the surgeries are really quite extensive where you're removing portion of their neck or maybe their voice box, things like that, or their breathing tube where they have to have a tracheostomy. So talk to us about some of the different types of surgeries that you're doing and obviously how that impacts patients.
Yeah. So some of the surgeries can be very small and they can go home the same day, such as removing part of the thyroid. Most patients can go home the same day. Removing a mass from the parotid gland, which is your salivary gland over here, pretty much the same day. Something like laryngeal cancer, if they need a total laryngectomy, which is removing the voice box, that requires a big surgery, usually takes all day. 10 hours or so, that we remove the voice box and then have to reconstruct it with tissue from other parts of the body. So it really varies the length of the surgery. Some are a couple hours, some are the whole day. So
wow. And then how does that impact patients? Obviously the parotids and the ones that you guys do through the mouth with robotic surgery, those patients can go on to normal lives, right?
Yes. So yeah, we do use the robot sometimes for the back of the tongue and the tonsil cancers. Those are really great. The patient stays over. It varies by institution how long they'll keep them in the hospital and how much support they'll give them. But typically patients are able to go home within a few days of surgery. The things that can happen long-term from some of the surgeries, I mean, we're dealing with a very critical part of your body. So speech, swallowing, speaking. Speaking involves you moving your tongue in a certain way. It involves your voice. So all of these things can be affected by the surgeries. So that's one of the things that I keep in mind when I'm counseling the patients or thinking about what kind of surgeries they need, is being very aware of how their life may change or how their recovery may be, because some of these things may be permanent.
Wow. And so it's hard to say because we're talking about a lot of different cancers and we're covering a lot of head and neck cancers. But overall, are head and neck cancers curable? Is it a really bad cancer? What's the overall prognosis for these patients?
That's very difficult to answer in general. I would say in general, I mean, it's like any cancer. If you catch it early stage, there's a high likelihood we can cure it.
Okay.
Catching it later stage, it's more difficult because again, sometimes they get so big that if it involves the carotid artery, let's say you need this artery in order to supply blood to your brain, and if that is involved, we can only give treatment that may not cure it, but at least keep it from growing. So it really depends on the site and how big it is and all of that. But
do these cancers metastasize as well? Do they go to other parts of the body?
They can, yes. Typically it's when it's later in its course, but they typically go to the lungs is one of the first places that we'll watch that long term to make sure.
All right. And then long term, once somebody has a head and neck cancer resected, are they at higher risk of having another one in their life?
Mm-hmm. Once you've made a head and neck cancer, you're at higher risk. So it is something that we watch very closely, and you're at high risk for having a recurrence. So there's a protocol of following patients once they have head and neck cancer. So for the first 1 to 2 years, we see you every 3 months. And then we kind of space it out from there to every 4 or 5 months, 6 months, every year. After 5 years, that's when we consider you officially cured. And then I would recommend that we see you once a year after that.
But that's for recurrence of your same cancer. What about a new cancer?
So it depends on the kind of cancer that you have and the type of treatment that you have. So if you get radiation for one of your cancers of the head and neck, you're at high risk for developing a second one.
Wow.
So that's something that we have to keep in mind too when we're following these patients.
And so you guys have to surveil them as well.
Mm-hmm.
And what does the surveillance look like? When they come in, you guys are putting cameras down in their nose and their throat and looking around. How is that? Or do they need imaging and so forth for that?
Typically, it's a physical exam, and we base our imaging studies on what we find on the physical exam. Immediately after the resection in that first year, we'll order a couple scans to make sure we got all the disease and that you haven't the high risk of recurrence occurs in that first year. And then the subsequent years, we do it based on exam and then go from there. The exam is typically just feeling and looking. And then there is a camera that we use. It's like the size of a spaghetti noodle, and we put it down the nose. It feels weird. It's not really painful per se.
No gagging?
No, typically people don't.
Okay.
Yeah. You have to keep your eyes open and focus on something on the wall if you're a gagger, but most people are able to tolerate it very well.
All right. So obviously great things you're doing. You're obviously helping patients, and we're trying to obviously detect these head and neck cancers, and you're trying to cure them. Obviously, as part of Miami Cancer Institute, there's a lot of research and protocols and a lot of trials going on. So talk to us a little bit about what you guys are doing in your area for head and neck cancers that you guys are doing locally and maybe collaborating with others around the country.
So one of the studies that we're doing is using a new type of therapy that's called Rakuten. So it's using this sensitive, like an immunotherapy that's tagged to a light. It's light sensitive. So it only turns on in the area where you shine light on it. So if you have a visible tumor that we're not able to remove, or it's been very recurrent or something like that, it's for recurrent cancers. So you had to have treatment before and it hasn't worked or whatnot. But we will put like a little rod or a device there to direct the light, and then we shine the light on it after you get the infusion, and it'll activate the medication in that area to kill the tumor cells.
And so, but that medication you give circulates through the whole body, but only is active in the area where the light is shined. Wow. Yeah. That's great.
And we have some other studies that are open for helping with symptom management with patients that are getting radiation treatment. We also have some protocols for different kinds of dosages and treatment areas that we treat for different kinds of cancers. So instead of treating both sides of the neck for certain cancers with radiation, we may just do one side or randomize it to see how those patients do, because there's data to show that we can potentially give less treatment and still have the same effect.
Wow. Now, you mentioned something about, I don't know if you said the word therapy, but you have to have a huge team of people to help because of what happens around the treatment of head and neck cancer.
Yes.
So talk to us about all those other people besides Dr. Crawley who help with, not only before surgery, but after surgery.
Yeah, it takes a little bit of an army. So we have speech therapy is very integral for patients to help do exercises and strengthen to relearn how to speak or move their tongue or swallow. It's very important. We also have physical therapy because a lot of the nerves that move your arms or control your tongue are up in the head and neck, and those can be affected from surgery or radiation treatment. So they have to see physical therapy. We also see nutritionists. Nutritionists work with us to help make sure that the patients, are able to maintain their body weight, and they may have to change the type of consistency of the foods that they're eating. And we also work with social workers and case managers because some of these people need a lot of supplies. So if someone has a total laryngectomy or they have a tracheostomy, they're going to need supplies for home. And so those people have to be in contact with
Yeah, it's important to have all those people working with you. So what I've learned today about head and neck cancer and is head and neck cancer awareness is that no smoking, no drinking. If I have a sore or something in my mouth that doesn't heal in a couple weeks or it's getting worse, seek medical attention. Anything else that you want to, really relay to our audience about head and neck cancer for them and for their family?
So I would also say if you want to feel your face and your neck too for any lumps and bumps, that's important as well for kind of checking it out. But overall, I think head and neck cancer patients, there's a good chance that they do pretty well. So, especially if you catch it early, then it can have a minimal impact on your quality of life. But even if it's a bigger surgery, there's a lot of things that we're able to do to help patients. So.
Yeah. Definitely. Well, thank you. Thank you, Dr. Crawley. Thank you to our audience. Thank you, Dr. Crawley, for being with us today, bringing awareness for head and neck cancer in April. And remember, obviously, check yourself out. If you notice something different, you notice a sore that's not healing for yourself or your family, please bring them to a medical professional. And obviously at Miami Cancer Institute, they're dealing with all of these more advanced cancers. Once again, Dr. Anthony Gonzalez from Miami Community Health. Be well, take care of yourself and your family. Have a great day.